Hello and welcome back to class. This is Applied Anatomy and Physiology, AAP 301 for the College of Natural Health Sciences, Bermuda. My name is Dr. Dalcina Bean Burrows, and this is lecture number 10. For the next series of lectures, we will be looking specifically at circulation and body defense. Today's lecture, we will look at the cardiovascular system. And what we will cover in today's lectures are, we will first take a look at the learning objectives. We will consider the key terms, blood vessels, the heart, circulation and dynamics of blood flow, inflammation and tissue healing, as well as aging and the cardiovascular system. So before we get started, just to put your mind in gear, why do you think the heart speeds up when we dance or play? And some recipients of a heart transplant demonstrate characteristics of the donor after the transplant. Why do you think that happens? So in terms of Lecture 10, Learning Objectives, at the end of today's lecture, you will be able to list the functions of the cardiovascular system and discuss their importance as they relate to the practice of manual therapy, identify the key components of plasma and explain their functional purpose, name the 3 types of blood cells and explain their functions, name the types of blood vessels and describe their distinguishing characteristics, identify and locate the primary arteries and veins and name those that might be affected by manual therapy, name the layers of the tissue in the heart and describe their functional contribution, identify the chambers, valves, and great vessels of the heart in the order that blood moves through them, explain the conduction system of the heart, how it creates the cardiac cycle, and mechanisms that regulate heart rate, name the 2 divisions of cardiovascular circulation and describe blood flow through each network of vessels, explain the primary influences on arterial, capillary, and venous blood flow and how they differ, define blood pressure, explain how it is regulated, and describe how the body responds to blood pressure fluctuations, list and describe the Starling forces that create fluid exchange in the capillary beds, list the 3 stages of tissue healing and describe the key physiologic events of each, and describe changes that occur in the cardiovascular system as the body ages. And here are the key terms that we will look at today: atrium, capillary fluid pressure, or CFP, cardiac, diastole, edema, endocardium, epicardium, hematopoiesis, hemoglobin, hemorrhage, hemostasis, hyperemia, interstitial fluid pressure, or IFP, ischemia, and lumen. Also, myocardium, pericardium, peripheral resistance, plasma oncotic pressure, or POP, pulmonary circuit, pulse, systemic circuit, systole, vasoconstriction, vasodilation, and ventricle. In our study of the cardiovascular system, we will consider the structure and functional components. We will look at blood flow, circulation, and inflammation and healing. We will also consider the motion and heart connection. We will look at manual therapy's impact on the circulatory system. And we will consider research and some unfounded claims. We begin our discussion about the cardiovascular system beginning with blood. Blood is a fluid connective tissue that consists of 2 components, a liquid portion, the plasma, and cell fragments called formed elements. Blood is the primary transportation medium for nutrients, waste, and chemicals such as hormones that are needed to support the body's metabolic activities. Nutrients enter the blood from the digestive and respiratory systems or are released from storage sites such as the liver. Blood also takes metabolic byproducts away from cells and carries them to the kidneys, liver, and spleen, where waste is either filtered out and usable components are recycled. Because it contains specific buffer chemicals, blood helps maintain the slightly alkaline pH body fluids within the homeostatic range of 7.35 to 7.45. Blood also serves as important thermoregulatory functions. It transports heat generated by muscle contraction throughout the body and dissipates it through breathing and the skin. Now let's discuss plasma. Plasma, the fluid component of blood, accounts for about 55% of blood volume. It is approximately 90% water and 10% dissolved or suspended trace elements and particles, including hormones and electrolytes. The largest portion of these substances consist of plasma proteins. Their presence in the blood supports fluid flow by helping blood to hold water and remain fluid. Plasma proteins also play an essential role in blood clotting and immune responses. The primary plasma proteins are the following: albumin. This is the most abundant type of protein found in plasma. Its primary role is to contribute to osmotic pressure and maintain blood volume. Albumin also acts as transport or carrier protein for steroid hormones and fatty acids in the blood. Globulins. This is the protein, includes antibodies, and it also defends the body against the viral and bacterial pathogens. It also includes complements that enhance certain immune responses, such as clotting factors that may help the blood to clot, and transporting proteins that carry iron, lipids, and certain vitamins in the blood. Fibrinogen. This is the protein which is converted into fibrin to form the thin initial threads of a blood clot. In terms of the formed elements, there are three types of cells that make up the formed elements of the blood. These blood cells are produced by stem cells in the red marrow of bone. Through a process called hematopoiesis, the stem cells divide and differentiate to produce three types of blood cells: red blood cells, white blood cells, and platelets. Now let's discuss red blood cells. Red blood cells, or RBCs, are also known as erythrocytes. They are responsible for transporting the oxygen needed for cellular metabolism. Hemoglobin is an iron-rich protein in the RBCs that binds with oxygen molecules. Blood carrying a great deal of oxygen, such as the blood leaving the lungs, has a brighter red hue created by the hemoglobin-oxygen bond. In contrast, blood returning to the heart is a darker red color because tissues have stripped away the oxygen from the hemoglobin molecules of the RBCs. While carrying oxygen is hemoglobin's primary role, it also transports carbon dioxide and hydrogen ions. Because carbon dioxide binds to a different part of the hemoglobin molecule than oxygen, its oxygen carrying capacity is only slightly reduced. Also, hemoglobin picks up hydrogen ions only after it has given up its oxygen. This ability to bind free floating hydrogen ions to hemoglobin gives RBCs an important role in maintaining blood pH. Mature red blood cells have a biconcave shape, meaning that they are concave or curved inward on both sides. They have a few organelles and no nucleus. The shape and composition of RBCs maximizes their hemoglobin and oxygen carrying capacity. But the lack of a nucleus also means that RBCs are unable to divide. Instead, new cells are produced by the red bone marrow through hematopoiesis. The average lifespan of RBCs is approximately 120 days, after which the liver or spleen destroys them. RBC production can also be stimulated in response to low oxygen levels in the blood. In these cases, the kidneys release the hormone erythropoietin, which stimulates hematopoiesis. Another important feature of RBCs is the presence of receptor integral membrane proteins, or IMPs, introduced in an earlier chapter, which serves as a protein identity marker called antigens. Scientists have identified more than 100 different antigens on the surface of RBCs. These antigens form 24 blood groups, each with 2 or more different blood types. One group of these antigens, the ABO blood group, allows blood to be typed according to the presence or absence of the A and or B antigen. Individuals with A antigen are said to have type A blood, and those with B antigen have type B blood. Those without either the A or B antigen have type O blood. In the United States, type O is the most common blood type, representing 45% of the population. Those with both protein markers in their blood are designated as type AB, and a very small number of people in the United States have this blood type, about 4%. Another antigen, first discovered in rhesus monkeys and found in a different area of the plasma membrane of RBCs, forms the Rh blood group. Individuals either have or do not have this antigen, so blood is identified as either Rh positive or Rh negative. If a person receives a blood transfusion with RBCs carrying antigens different from their own, the blood will identify the antigens as foreign and produce a defensive immune response. This is why individuals must go through meticulous blood typing procedures before any type of surgery or transfusion is given. By the way, people with type O negative blood are referred to as universal donors because their RBCs have neither Rh nor AB antigens. This means that RBCs are the least likely to trigger an immune response in people with other blood types. By contrast, those with type AB positive blood are considered universal recipients because their RBCs have all 3 antigens. This means they can receive RBCs from all blood types and have the lowest likelihood of experiencing an immune response. Now let's consider white blood cells. Leukocytes, or white blood cells, WBCs, play a vital role in healing and the body's immune response. They are outnumbered by red blood cells by a ratio of 700 to 1. White blood cells have a much shorter lifespan than red blood cells and may circulate for only 6 to 8 hours. But white blood cells that migrate into the body tissues can survive much longer, sometimes months or years. Leukocytes are round cells with a prominent nucleus. There are 5 types that fall into broad categories: granular or agranular, according to the appearance of their cytoplasm. Granular leukocytes, which are involved in inflammation and tissue healing, include neutrophils, basophils, and eosinophils. Agranular white blood cells, which include lymphocytes and monocytes, play more specific roles in the immune response. And here we see illustrated in Table 10 white blood cells categorized according to granular or agranular. We know that neutrophils, basophils, and eosinophils are granular white blood cells, while agranular are the lymphocytes and monocytes. Neutrophils, which are granular white blood cells, make up 60 to 70% of all white blood cells, while lymphocytes, which are agranular, make up only 20 to 25% of all white blood cells. Let's take a look at platelets. Platelets, or thrombocytes, are actually cell fragments that contain mitochondria and a number of active enzymes that are necessary for their function. Like red blood cells, or RBCs, platelets cannot reproduce through mitosis because they do not have a nucleus or DNA. Produced in red bone marrow, platelets are much smaller than red and white blood cells and have a lifespan of about 10 days. Platelets play a key role in hemostasis, the process that stops bleeding or blood flow. Hemostasis is a complex process that is initiated when cells inside the blood vessel release specific chemicals, setting off a chain of events that leads to the formation of a clot or patch that prevents further blood loss. We also see in the illustration here that there are 3 stages or 3 steps that are involved in hemostasis. In the vascular stage or vascular spasm stage, this is when blood vessels are damaged and the cells of the vessel wall release chemicals that signal the smooth muscle inside the wall to constrict and slow the flow of blood through the injured vessel. There is then a platelet plug, and this is when the chemicals released from the damaged cells cause platelets to become sticky and to clump together to form a soft temporary plug over the damaged area of the vessel. And then we also have clot formation. This is when, in the final step, also called coagulation, the cells in the platelet plug release clotting factors. These combine prothrombin and plasma to form thrombin. Thrombin reacts with fibrinogen in plasma to form fibrin, which is a thin protein thread that forms a net around the platelet plug. This netting traps red blood cells and platelets to form a clot. And here we see illustrated the formed elements of blood. 3 types of cells make up the formed elements of blood: the thrombocytes, which are the platelets, the erythrocytes, which are the red blood cells, and the leukocytes, which are the white blood cells. So here is our first What Do You Think segment for this lecture. Explain how the role of each formed element is reflected in the number of each cell type. Given your understanding of clotting and platelet function, what is the danger posed by diseases that create rough spots in blood vessels? And again, our What Do You Think segments, you do not have to submit the answers to these questions. This is just something to help you develop your clinical reasoning skills. So do your very best to answer these questions in your mind. If you want to write them out on paper, this will just help you to really develop your clinical reasoning skills as you become a holistic health practitioner. Now let's take a closer look at the blood vessels themselves. We will discuss the arterial vessels, which includes the arteries and the arterioles. We will discuss the capillaries, and we will also look at the venous vessels, which includes the veins and the venules. And here we see illustrated the structure of blood vessels. The walls of arteries and veins are made up of the same three layers. While arteries have a thicker middle muscular layer, veins have a thicker outer elastic layer and one-way valves to prevent backflow of blood. Capillaries are made of single layer of epithelial cells attached to a thin basement membrane. And here we see illustrated the process of hemostasis. Hemostasis stops bleeding or blood flow. First, there is vascular spasm. Smooth muscle contracts to constrict the vessel. Second, we have platelet plug formation. Platelets are activated by chemicals released from the damaged cells. They become sticky and attract more platelets. And third, we have coagulation. Fibrinogen is converted into fibrin, which forms a clot with platelets and red blood cells. Bleeding, therefore, stops. Now let's take a look at arteries and arterioles. In arteries, the middle muscular layer is much thicker than the same layer in veins. This thicker and more elastic middle layer gives arteries the ability to expand and recoil to withstand the pressure and volume of blood that is pumped from the heart. Smooth muscle contractions control the size of the vessel's lumen, which is essential for the regulation of both blood pressure and distribution. Vasoconstriction is the narrowing of a blood vessel when the smooth muscle contracts, causing blood flow through the vessel to diminish and pressure to elevate. In contrast, vasodilation is the widening of a vessel due to smooth muscle relaxation. This increases blood flow and can decrease blood pressure. While arterioles are much thinner than arteries, they still have enough smooth muscle to maintain blood pressure and help control blood distribution to the capillaries. At the end of each arteriole is an extra ring of smooth muscle called the precapillary sphincter, which regulates the volume and rate of blood flow into the capillaries. The blood distribution pathway formed by the arterial vessels is a continuous network branching out from the heart to the capillaries. To distinguish one section of the network from another, major arteries are named according to their location, body region, or the organ they supply with blood. The aorta is the great artery that connects the heart. Almost immediately after it ascends from the heart, three major arteries branch off the aorta. The brachiocephalic artery, which branches again to become the right carotid and subclavian artery, the left carotid artery and the left subclavian artery. The carotids ascend to the neck and head, while the subclavian arteries travel to the upper extremities. In each armpit, the subclavian artery becomes the axillary artery. The axillary artery becomes the brachial, which then branches into the radial and ulnar arteries, and finally, the palmar and digital arteries of the hand and fingers. The aorta travels behind the heart and downward through the thoracic cavity as the descending aorta. It continues through the abdominal pelvic cavity, where it is called the abdominal aorta. The cephalic trunk is the first branch of the abdominal aorta. It further branches into the common hepatic or liver, left gastric stomach, and splenic spleen arteries. The mesenteric arteries supply the intestines, and the renal arteries carry blood to the kidneys. At the level of the fourth lumbar vertebrae, the abdominal aorta splits into the right and left common iliac arteries, which deliver blood to the lower extremities. Each common iliac artery has two major branches that supply the tissues and organs in the pelvis: the internal and external iliac arteries. From this point, the major arteries of the lower extremity are the femoral, popliteal, anterior and posterior tibial, and the dorsalis pedis. And here we see the major arteries and pulse points of the body. Small black dots designate major pulse points, which are sites where a portion of an artery is superficial. Now let's take a look at the capillaries, or capillaries. The capillaries, situated between the arterioles and venules, form an intricate network of microscopic vessels called a capillary bed. This web of interconnected vessels is found throughout the tissues and serves as the site for nutrient and waste exchange between the blood and interstitium. Capillary walls are made of single layer of epithelial cells that are covered with a thick, sticky layer of sugar and protein strands called glycocalyx. This additional layer helps to keep the epithelial cells from being stripped away by blood flowing through the capillary. Externally, the vessels are wrapped in a very thin connective tissue membrane. The density of capillary beds varies according to the metabolic demand of the particular tissue or organ. Tissues and organs with high metabolic demands, such as the brain, liver, skeletal muscles, and kidneys, are densely packed with capillaries. In contrast, ligaments, tendons, and cartilage have very few capillaries since their metabolic needs are extremely low. And here we see illustrated a capillary bed. Capillary beds sit between the arterioles and venules and serve as the site for nutrient waste exchange. The flow of blood through the capillary bed is regulated by the precapillary sphincters. Now let's discuss veins and venules. In contrast to arteries, veins have a much thinner muscular layer. This makes them more distensible, which means able to expand, and allows high volumes of blood to be transported as needed. A unique structural feature of veins is the series of one-way valves interspersed throughout their length. These valves prevent backflow and create shorter segments for the blood to travel through its return to the heart. With a few exceptions, most of the major veins have the same name as the artery in that same region. In the upper extremity are the digital, palmar, radial, ulnar, brachial, and axillary veins. Additionally, in the antecubital region, 3 superficial veins also return blood from the arm. The basilic vein is the most medial, the median cubital is in the middle, and the cephalic vein is the most lateral. Its accessible superficial location makes the median cubital vein the preferred site for drawing blood or for intravenous injections of drugs or fluids. The median cubital joins with the basilic and cephalic veins in the elbow region. The basilic and cephalic veins merge into the axillary vein, which then becomes the subclavian vein. The major veins that return blood from the head are the jugular veins. The right and left subclavian and jugular veins merge into the brachiocephalic veins before connecting to the superior vena cava. In the lower extremity, the major veins are the same as the arteries, with one major addition. The saphenous vein runs the full medial length of the leg before merging with the femoral vein. The saphenous vein is the long vein in the body and the one most prone to the condition called varicose veins, which is enlarged and twisted veins. All the major veins in the pelvic region and the abdominal pelvic cavity are named for the organs they serve. They eventually merge with the inferior vena cava, which connects the heart. However, the splenic, gastric, pancreatic, and mesenteric veins first merge with the portal vein, which enters the inferior aspect of the liver. In this case, venous blood is carried into the liver to be cleansed, and blood leaving the liver exits via the portal vein before merging into the inferior vena cava. And here we see illustrated the major veins. In illustration A, we see the superficial and deep veins, while in illustration B, we see the veins leaving the stomach, the spleen, the pancreas, and the intestines, which merge to form the portal vein, which carries blood to the liver for cleansing. The hepatic vein carries blood from the liver to the inferior vena cava. Here's our next What Do You Think segment. Why is the term artery used to describe major thoroughfares? What type of tissue do you think the venous valves are made of and why? We will now look more in depth at the heart, beginning with the basic components, followed by the heart chambers, the great vessels and the valves, blood flow through the heart, conduction system, the cardiac cycle, and regulation of heart rate. Now let's take a look at the basic components of the heart. Located center and slightly left in the mediastinum of the thoracic cavity, the heart is a 4-chambered pump shaped like an upside-down pear. Its broader superior border, or base, sits under the sternum at the level of the first rib, while its smaller inferior region, or apex, rests atop the diaphragm. The base is relatively fixed in position, while the apex shifts and slides as the heart pumps. The heart is surrounded by a protective sac called the pericardium. The outermost layer of this sac, the fibrous pericardium, is made of tough, disorganized fibrous connective tissue that protects the heart anchors it in place and keeps it from overstretching. The inner portion, or serous pericardium, is a two-layered serous membrane that produces pericardial fluid, which acts as a lubricant to decrease friction between the layers when the heart pumps. The outer parietal layer of the serous pericardium is fused to the inside surface of the fibrous pericardium, while the inner visceral layer is firmly attached to the heart itself. In diagram 2 illustrated here, we see the position and coverings of the heart. In A, the heart is located in the mediastinum of the thoracic cavity. The superior portion of the heart is called the base, while the apex is the inferior point formed by the left ventricle. The double-folded sac of serous membrane around the heart is the pericardium. The internal portion is the visceral pericardium, and the external portion is the parietal layer. In illustration B, the heart wall has three layers of tissue: the epicardium, the pericardium, and the endocardium. Now let's consider the heart chambers, the great vessels, and the valves of the heart. The heart is divided into right and left sides by a muscular partition called the septum. Each side has an upper chamber, or atrium, and a lower chamber called a ventricle. Blood returns to the heart via the veins entering the atria, receiving chambers. The left atrium receives blood that has been oxygenated in the lungs from the pulmonary veins. Deoxygenated blood from the body is returned to the right atrium via the superior and inferior vena cava. The ventricles are discharging chambers that forcefully pump blood from the heart into the arteries. The right ventricle pumps blood into the pulmonary artery, while the left ventricle forces blood into the aorta. The heart has four valves at important structural junctures that control the direction of blood flow through the heart. Two valves, the atrioventricular or AV valves, are located between the atria and the ventricles on each side of the heart. The valves are named based on the number of flaps or cusps they have. The right AV valve is the tricuspid valve, while the left AV valve is the bicuspid valve, also known as the mitral valve. The other two valves are called semilunar valves because of their curved half-moon shape. The semilunar valves are located between the ventricles and the major arteries to which they direct blood. The left semilunar valve is called the aortic valve, while the pulmonary valve is the semilunar valve located between the right ventricle and the pulmonary artery. Operating like a one-way swinging door, each valve keeps blood from flowing back into the wrong chamber as the heart contracts and relaxes. And here we see illustrated, illustration A, we have an anatomical view of cardiac blood flow. The direction of blood flow through the heart is controlled by the opening and closing of the four cardiac valves. And here we see illustrated in illustration B, a schematic view of cardiac blood flow. The schematic view provides a more linear representation of cardiac blood flow. Let's take a closer look at coronary circulation. The organization of the great vessels, chambers, and valves of the heart provides the means for organized blood flow. Remember that a septum separates the right and left sides of the heart, so each side creates its own circuit. Blood flows from the pulmonary veins into the left atria. From the left atria, blood is pushed through the mitral or bicuspid valve into the left ventricle. The ventricle then contracts to pump blood through the aortic valve into the aorta to be distributed throughout the body. As blood returns from the body, it ends up in either the inferior or superior vena cava and flows through these veins into the right atrium. It then flows through the tricuspid valve and into the right ventricle. Next, the ventricle contracts, forcing blood through the pulmonary valve and into the pulmonary artery. A short distance from the heart, the pulmonary artery splits to deliver blood to both lungs. Like all tissues, the heart wall must have a blood supply to provide nutrients and remove waste products. But the blood that flows through the heart moves too quickly to enable this exchange with the thick myocardium. Instead, a system of vessels throughout the myocardium takes care of the metabolic needs of the cardiac muscle tissue. The blood that flows through this system is called coronary circulation. In illustration A, we see that circulation is provided to the heart muscle via the coronary vessels. The major vessels of the coronary circulatory loop are shown also. Let's now discuss the conduction system of the heart. The pumping action of the heart is produced through the rhythmic contraction of the myocardium. As you may recall, cardiac muscle is striated, similar to skeletal muscle tissue, but cardiac muscle fibers are shorter, branched, and connected to neighboring fibers by thickened areas of sarcolemma. Transverse connections, called intercalated discs, hold the muscle fibers together and form specialized gap junctions that allow action potentials to be carried from one fiber to the next. This allows large sections of the myocardium to contract as a single unit without individual innervation of each fiber. The entire myocardium is divided into two functional networks of interconnected cells, an atrial network and a ventricular network. Approximately 1% of all cardiac muscle cells have an inherent rhythmicity. This means they are self-excitable or are able to generate action potentials on their own. Since cardiac fibers can pass action potentials from one to another, these autorhythmic fibers are responsible for both setting the pace and coordinating the contraction of all cardiac muscles to create an efficient pump. These specialized fibers are organized into a coordinated conduction system made up of the following components. The Sinoatrial Valve, or the SA node. It is located in the wall of the right atrium, just inferior to the opening of the superior vena cava, and this collection of autorhythmic cells serves as the heart's pacemaker. The SA node self-generates action potentials at the rate of 100 per minute, signaling the rest of the atrial cardiac muscle tissue to contract. The AV node, or atrioventricular node, is located in the inferior portion of the septum between the atria. The cardiac fibers of the AV node do not contact as often as the cells of the SA node, so this structure acts as an area of delay, holding back the conduction of action potentials until both atria have fully contracted.
atrioventricular or AV bundle are from the AV node, and the action potential passes into the AV bundle. It's also known as the bundle of His within the interventricular septum. In a healthy person, this is the only region where action potentials pass from the atria to the ventricles. The right and left bundle branches. These are the AV bundle branches left and right to carry the action potential down to the interventricular septum to the apex of the heart. We also have the Purkinje Fibers. These fibers are named for Czech physiologists who discovered them in 1839. The Purkinje fibers carry action potentials through the ventricular myocardial network to produce contractions of the ventricles, resulting in a ringing action. These components of the conduction system create an organized pathway for action potentials to be initiated and passed across the myocardium. In short, the SA node initiates the contraction sequence of generating an action potential that quickly spreads across both atria. The AV node assures that the entire atrial network of cardiac cells has contracted before passing the action potential onto the AV bundle. The coordinated contraction of the ventricular network occurs as the AV bundle passes the impulse down to the apex of the heart via the bundle branches, and finally up and across the rest of the ventricular myocardial tissue via the Purkinje fibers. And here we see illustrated cardiac muscle tissue and the conduction system. In illustration A, cardiac muscle fibers are striated, branched, and connected by intercalated discs. In illustration B, the contractions of the heart rate are controlled by its conduction system. Now let's consider the cardiac cycle. A cardiac cycle refers to the ordered sequence of atrial and ventricular contraction and relaxation that makes up one heartbeat. Simply put, a single heartbeat involves contraction of the two atria while the ventricles relax, followed by ventricular contraction as the atria relax. The term systole refers to a contraction state of the heart chambers, while diastole refers to a relaxation state in which the chambers dilate as they fill with blood. The cardiac cycle involves three phases. Relaxation phase, which is the cardiac cycle starting when the ventricles begin to relax and join the atria in a brief phase of mutual diastole. As the ventricles relax, the pressure within them eventually drops below the pressure in the blood-filled atrial chambers. This allows the AV valves to open and blood to flow into the ventricles. About 75% of total blood volume with the atria enters the ventricles during this phase. The atrial systole phase, or atrial systole, the SA node generates an action potential that causes the atria to contract while the ventricles continue in diastole. This atrial systole forces the blood left in the atria through the open AV valves into the ventricles. During ventricular filling, the semilunar valves are closed, and we have ventricular systole. As the impulse is passed through the bundle of His to the bundle branches and Purkinje fibers, the ventricles contract. The AV valves close and the pressure within the ventricle rises. Eventually, the pressure in the ventricles forces the semilunar valves to open and blood flows from the right ventricle into the pulmonary artery and from the left ventricle into the aorta. During ventricular systole, the atria are experiencing diastole, which allows them to fill with blood from the great veins. Once the ventricles eject their blood and begin to relax, the cycle starts all over again. The entire cardiac cycle takes less than 1 second in a healthy adult when at rest. This translates to an average resting heart rate of about 72 to 84 beats per minute. The lob, dub, lob, dub sound we call the heartbeat is actually the sound created by the closing of the heart valves. The lob part of the sound occurs when the AV valve shut at the start of ventricular systole, and the dub sound is the closing of the semilunar valves. The pause between heartbeats correlates to the relaxation phase. When heart rate increases, the relaxation phase shortens, and there is no real pause between heart sounds. And here we see illustrated the 3 phases of the cardiac cycle of the heart. In the first phase, which is the relaxation phase, we have semilunar valves closing, the atrioventricular valves are open, and the flow is from the atria to the ventricles. In the second phase, which is atrial systole, we have ventricular diastole, we have the semilunar valves which are closed, the atrioventricular valves are open, and the flow is from the atria to the ventricles. And in the ventricular systole phase, we see that the atrial diastole occurs. We have semilunar valves that are open, the atrioventricular valves are closed, and the flow is from the ventricles to the great vessels. Let's now consider the manual therapy applications with respect to the heart. Scientific studies of the effect of manual therapy on the cardiovascular system have often focused on changes in heart rate, blood pressure, and circulation. It has generally never been considered that manual therapy might impact the heart directly. But research in neurocardiology shows that with every beat of the heart, signals are sent to the brain and other organs, causing them to act in synchronicity with the heart's rhythm. While research has proven that manual therapy can decrease stress and anxiety, the physiologic mechanisms that produce this change are unclear. In a good deal of the literature, it is hypothesized that the mechanisms for decreasing stress and anxiety are related to increasing parasympathetic stimulus or decreasing sympathetic tone. Studies on coronary disease have repeatedly shown that factors such as loneliness, grief, cynicism, hostility, and anger are often stronger indications of heart disease than family history, cholesterol, smoking, or obesity. The practice of active listening to a client's history and stories supports a therapeutic relationship that can help a client heal from emotional trauma. It seems that holistically connecting with clients can help to dispel loneliness or create the space and opportunity for an emotional release that allows them to let go of emotions that are destructive to the heart, such as grief, anger, and hostility. Could it be that our greatest effect on the cardiovascular system comes not from changes mediated by the brain and nervous system, but by touching the heart with positive intentions such as gratitude, compassion, and love? Now let's consider regulation of heart rate. Factors including age, gender, fitness level, emotional state, temperature, and exercise all affect heart rate, which can vary considerably over the course of a day. Key physiological mechanisms that monitor and regulate heart rate include the following: the autonomic nervous system. The cardiovascular center of the medulla oblongata adjusts heart rate based on sensory input from a variety of receptors. Chief among these are baroreceptors in the sinus at the fork of the left and right common carotid arteries, which monitor blood pressure, and chemoreceptors, which monitor changes in blood chemistry. The cardiovascular center communicates with the SA and the AV nodes via the autonomic nerve fibers. In terms of hormones, the heart rate alters in response to hormonal changes, including adrenaline and noradrenaline released from the adrenal medulla during the alarm response. Thyroid hormones that increase metabolic rate also stimulate an increase in heart rate. And we also have ion levels. Elevated blood levels of sodium and potassium ions decrease heart rate and contractility, while elevated calcium levels tend to increase the rate and strength of the heartbeat. And we've come upon our next What Do You Think segment. Why is the word atrium a good term for a receiving chamber of the heart? 98% of all veins carry deoxygenated blood. What are the names of the veins that are against this rule? Name situations in which your heart rate has been elevated or decreased. What mechanisms do you think were responsible for mediating these changes? So in respect to our further discussions of circulation and the dynamics of blood flow, we will consider the pulmonary circuit, the systemic circuit, the arterial flow, capillary flow and exchange, venous flow, and regulation of circulation. And here we see illustrated the circulation and dynamics of blood flow with respect to the pulmonary and systemic circuits. The cardiovascular circulation involves the pulmonary and systemic circuits. The pulmonary circuit circulates blood between the heart and the lungs, while the systemic circuit is the blood flow between the heart and the rest of the body. The red arrows or the red illustrations of the circulation indicate the blood in high oxygen. The blue indicates the blood in low oxygen. Now let's consider arterial flow. Arterial blood flow is driven by the combined forces of ventricular contraction and arterial recoil. Ventricular systole forcefully pumps a large volume of blood into the 3 arteries leaving the heart. Arteries can usually accommodate only about 1/3 of the blood forced into them. The remaining blood being pushed through causes the arterial walls to stretch and bulge. During ventricular diastole, the artery recoils, creating a secondary push that propels the remaining blood farther down the arterial network. This bulge and recoil reaction is propagated through the arterial network, although the force it generates is diminished in the distal arteries. Arterial expansion and recoil can be palpated as a pulse in a few of the superficial arteries. Because it is generated by ventricular contraction, it provides an accurate assessment of heart rate. The major pulse points of the body are indicated by black dots in figure 10.4, which we will look at. Another key influence on blood flow through the arteries is blood pressure. Blood pressure is a measurement of the hydrostatic pressure generated by blood against the vascular wall. This measurement consists of two numbers stated in terms of millimeters of mercury. The high number is the systolic pressure, which represents the pressure generated during ventricular contraction. The diastolic pressure is a lower number that represents the pressure in the arteries when the ventricle relaxes. According to the American Heart Association, a reading of 120 to 80 milligrams Hg is considered optimal for a healthy adult. Blood pressure changes occur throughout the day to meet circulatory demands. For example, standing upright poses more of a challenge to maintaining blood returning to the heart than lying down. So blood pressure must increase to meet this demand as it happens upon arising each morning. Numerous factors affect blood pressure. Some of the most common are blood viscosity, blood volume, elasticity of the vessel walls, and efficiency of the heart. In the diagrams we see illustrated here, we see arterial flow. The force of ventricular contraction ejects blood into the arteries, creating a bulge and recoil response that is a major influence on arterial blood flow. Now let's consider capillary flow and exchange. Blood flow into the capillaries is controlled by the precapillary sphincters. These smooth muscle sphincters constrict and dilate to control both the volume and rate of blood flow into the capillaries. A central pathway called the thoroughfare channel in each capillary bed allows blood to pass straight through when metabolic need is low. But when demand increases, the capillary sphincters open to allow the entire capillary bed to fill so that nutrient waste exchange can take place. Capillary exchange between blood and interstitial tissues involves the movement of particles or solutes as well as fluids. Solutes, including oxygen, carbon dioxide, and glucose, move by simple diffusion through the capillary wall. Fluid is exchanged between the blood and interstitium through a combination of hydrostatic and oncotic pressures. This is the osmotic pressures in the capillary wall, which is produced by proteins. These pressures are collectively referred to as the Starling forces. The movement of plasma and its dissolved solutes out of the blood into the interstitium is called filtration. Reabsorption refers to the movement of fluid and substances back into the capillary bed. Both CFP and IOP create filtration, whereas IFP and POP are the forces involved in reabsorption. For years, it was believed that filtration due to CFP occurred only at the arterial side of the capillary bed, and that this fluid filtration increased the concentration of plasma proteins within the vessel. This resulted in increased POP, which was theorized to promote resorption of fluid at the venule end of the capillary bed. But in fact, more than 100 years ago, British physiologist Ernest Henry Starling, for whom the forces are named, calculated that 90% of capillary filtrate was reabsorbed back into the capillaries. And here we see illustrated the capillary flow and exchange. And of course, we have the Starling forces, which is the capillary fluid pressure, or CFP, the interstitial fluid pressure, which is IFP, the plasma oncotic pressure, which is POP, and the interstitial oncotic pressure, which is ICP. Capillary exchange is controlled by the 4 Starling forces, as we have seen illustrated. In a healthy body, the volume of fluid regularly filtered from the capillaries into the interstitium is absorbed and returned to circulation via the lymphatic system. Occasionally, the volume of capillary filtrate overwhelms the lymphatic system and extra fluid accumulates in the interstitium. This excess interstitial fluid is called edema. Conditions that can lead to edema include hypertension, pregnancy, obesity, diabetes, musculoskeletal trauma, and cardiac and kidney dysfunction. Now let's consider venous flow. Because the pressure created from the heart contraction has dissipated by the time blood enters the venules and veins, the physiologic mechanisms for venous flow are more external than those of arterial flow. Skeletal muscle contractions apply external compression to the veins, which helps propel blood back toward the heart. One-way valves assist venous flow by creating shorter segments for blood to travel. In the ventral cavities, where the large veins are not surrounded by skeletal muscles, the driving force for venous flow is the respiratory pump. This pump is created by the positive and negative pressure inside the thoracic and abdominopelvic cavities that occurs during breathing. Venous flow is also affected by gravity, which works against it most of the time. In our diagram, we see the skeletal muscle pump. Skeletal muscle contraction plays an essential role in venous blood flow. The contraction creates external compression of the veins, which assists in moving blood back to the heart. Let's now take a look at regulation of circulation. Every day, the cardiovascular system is challenged to maintain adequate blood flow to all body tissues and make circulatory shifts to adapt to the body's changing demands. Changes in aspects such as temperature, activity level, and emotions can require changes in circulation affecting organs and tissues throughout the body. Local shifts in the volume and flow of blood are known as ischemia, a decrease in blood volume or flow, and hyperemia, which indicates an increase. In general, there are 2 guiding principles for the regulation of circulation. First, circulation is increased in active tissues and decreased in those that are less active. Second, blood flow to the vital organs must always be maintained. For example, in cases of extreme cold or blood loss, blood flow to the brain, lungs, and heart is prioritized over that of other body parts. The body has 3 key physiologic mechanisms that monitor and regulate circulation. The first is autoregulation. Most body tissues have some ability to signal and create local short-term changes in circulation. For example, during hemostasis, injured cells release chemicals to signal an immediate vasospasm to decrease blood flow in a damaged vessel. Another example is tissue response to local applications of heat and cold. A hot pack creates vasodilation, while a cold pack causes vasoconstriction. Then we have the nervous system regulation. As described in our earlier lecture, the smooth muscle in blood vessels is innervated by sympathetic neurons and controlled by the vasomotor center in the medulla oblongata. When a sympathetic response is stimulated, vasoconstriction occurs in most organs and tissues, while vasodilation occurs in the skeletal muscles. The activity of the vasomotor center is altered by several factors including emotional state, blood pressure, pain, and oxygen and carbon dioxide levels. Additionally, dramatic shifts in blood flow accompany changes in heart rate. Recall that the cardiovascular center of the medulla oblongata moderates heart rate in response to stimulus from various sensory receptors. And then we have hormones. Local hormones, such as the prostaglandins, promote vasodilation in local blood vessels. Prostaglandins are released when tissue is damaged, and the adrenaline and noradrenaline cause the same vascular responses as the sympathetic neurons. In this case, vasoconstriction in general, but vasodilation in the skeletal muscles and in the heart. Let's now consider the effects of manual therapy in terms of circulation and dynamics of blood flow. Increased circulation is one of the most widely claimed physiologic effects of manual therapies, especially massage. But it is difficult to find current and well-designed research that supports this claim. Circulation involves arterial blood flow away from the heart, capillary flow and exchange, and venous return of blood to the heart, a complete circuit starting and ending with the heart. Since circulation is regulated by several complex physiologic processes, it is important not to confuse local changes in blood flow with systemic circulatory changes. For example, hyperemia and ischemia indicate low vasodilation or vasoconstriction. They do not reflect systemic changes in blood flow and circulation. In fact, local changes in blood flow and pressure demand homeostatic adjustments that maintain adequate circulation throughout the body. Some research shows that massage may be effective in moving blood through some superficial veins and out of local capillary beds, and that it can create some histamine release that results in local hyperemia. But there is no scientific evidence that points to systemic enhancement of circulation. Even well-supported systemic physiologic effects of massage, such as decreased heart rate and blood pressure, are only short-term changes that could actually decrease overall systemic circulation. This is not to say that manual therapies have no positive effect on the cardiovascular system. Rather, research does not support the claim of increased systemic circulation. Even the most recent research on fascia and its connections with the autonomic nervous system refers only to changes in blood pressure and local circulation. While we may hypothesize that movement therapies enhance local venous flow due to muscle contraction, or that energy techniques that increase or balance energy are beneficial to circulation, there is little rigorous scientific research to support these hypotheses. Ongoing research in neurocardiology may offer new insights into possible systemic effects of massage on the cardiovascular system. Time again for our What Do You Think segment. In cases of hypertension, would you expect a pulse to be strong and pounding or thin and weak? When you are frightened, in what tissues and organs does vasoconstriction occur? Explain how hypertension and pregnancy can create swelling in the ankles. And how do you think manual therapy affects local venous flow? For this next segment of our lecture, we will consider inflammation and tissue healing. We will specifically look at tissue damage, and we will also consider the stages of healing, which is the acute stage, the subacute stage, and the maturation stage. When tissue damage occurs, the hemostasis process stops any active bleeding or hemorrhage in a fairly short time frame. Simultaneously, inflammation and additional protective response is initiated to help stabilize the damaged tissues and prepare it for repair. Since tissue healing requires delivery of important repair materials and cleanup of damaged cells, the cardiovascular system plays a vital role in both the chemical and cellular processes of the inflammatory response. The key physiologic processes of inflammation include vasodilation, changes in capillary permeability, clot formation, and phagocytosis. Vasodilation and capillary permeability are enhanced when histamine is released by mast cells, basophils, and platelets. These tissue changes allow the cells and chemical mediators required for cleanup and repair to flood the affected area. Some of the major components delivered via blood are platelets and clotting factors for hemostasis, neutrophils, and other phagocytes for cleanup, and fibroblasts and proteins for tissue repair. Other chemicals released to support vasodilation and increase capillary permeability. These include local tissue hormones such as prostaglandins and leukotrienes and complementary factors in the blood. Homeostasis and inflammation are the initial tissue responses to trauma. The entire healing and repair process is divided into 3 phases: acute, subacute, and maturation stages of repair. The rate at which the entire process occurs and the time it takes the body to move through each phase depend on a variety of factors, including the type and amount of tissue damage, the tissue's vascularity, and the individual's overall nutritional health and fitness status at the time of the injury. So when we are looking at tissue damage, we are first looking at the stage of hemostasis, followed by hemorrhage, and then the inflammatory stage or inflammation, where we will see vasodilation, capillary permeability, clot formation, and phagocytosis. Now let's consider inflammation and tissue damage. We will look specifically at the acute stage of healing. During this stage, pain and muscle spasms are present. There is secondary edema formation, and we have what is referred to as hematoma organization. In diagram A, we see illustrated margination. Toward the end of the acute stage of tissue healing, the number of phagocytes and leukocytes decreases as fibroblasts increase. The fibroblasts migrate to the perimeter of the edema, which is referred to as margination, to form a hematoma. Let's consider the manual therapy applications with respect to inflammation and tissue damage. Since therapists cannot look inside damaged tissue and see the ongoing physiologic responses, they must rely on a set of external indicators to determine the presence of tissue damage and the most likely stage of healing and repair. Although a multitude of different signs and symptoms must be considered, the key external indicators of musculoskeletal trauma and repair status are summarized by the mnemonic CHAPS. C is for color change, H is for heat, A is for asymmetry and or a loss of function, P is for pain, and S is for swelling. In terms of color change, erythema, which is redness over a site of injury, is a clear indicator of vasodilation and chemical activation in the inflammatory response process. While this is a helpful sign, it may be difficult to detect if people with darker skin, so you need to look for any noticeable change in color. With respect to heat, an increase in tissue temperature clearly indicates the body is actively involved in hemorrhage and or inflammation. In terms of asymmetry and or a loss of function, there will be a visible or palpable change in a tissue's contour, borders, texture, or shape is a good indicator of injury. A decrease in tissue function, such as range of motion and or strength, is also a general indicator of injury. Because both can be apparent at any stage of tissue healing, they are better indicators of the severity of a trauma, whether it is mild, moderate, or severe, than of the stage of healing. Pain. As previously discussed, pain often accompanies trauma and injury. The quality of the pain and where it occurs during range of motion helps therapists determine the stage of healing. Stabbing pain that limits movement or occurs in multiple points of active motion is a good indicator of the acute stage. Swelling. Swelling of the area is a result of both primary and secondary edema. Now let's consider the subacute stage of healing. During the subacute stage, which is also referred to as the proliferative stage, tissue repair begins. Resorption of leukocytes and phagocytes into the lymphatic and cardiovascular capillaries is completed, and the number of fibroblasts increases. While muscle splinting is an important protective response that follows hematomal organization in the acute stage, continued spasm and splinting can create ischemia in the tissues, limiting the cleanup and repair process in the subacute stage. With sufficient circulation, fibroblasts proliferate and begin to synthesize fragile thread-like fibers called granulation tissue throughout the hematoma. These fibers are laid down in a haphazard multidirectional web across the entire hematoma. Once granulation tissue has fully inundated the area, the process of thickening and strengthening the fragile granulation fibers into full-strength collagen begins. During this process of collagen remodeling, some granulation threads are dissolved and recycled to make other fibers stronger. Fibers that are in good alignment with the normal lines of stress of the tissue become thickened, while those in poor alignment are dissolved. For example, in muscles with a vertical fiber alignment, the vertical granulation fibers are thickened, while those with a horizontal or oblique fiber direction are dissolved. Now, in terms of the manual therapy applications, proper alignment of collagen repair fibers cannot occur without using movement to show the body the normal lines of stress in the tissue. This prevents tissue from developing thick, poorly aligned, matted repair patches, which is especially important in tissues with highly organized fiber arrangements such as the muscles, ligaments, and tendons. Disorganized repair patches can disrupt normal tissue function and irritate surrounding healthy tissue. Movement during the subacute phase is also important because it facilitates lymphatic and venous fluid return. In the latter part of the subacute stage, therapists may also initiate some form of cross-fiber tissue manipulation to break apart the fibers that interfere with proper fiber alignment in the tissue. But great care must be taken not to further damage the tissue and return it to the inflammatory stage. And now let's consider the maturation stage of healing. The key physiologic event in the maturation or remodeling stage is the continuation and completion of the collagen remodeling process. Again, sufficient circulation in the damaged tissue is essential for rapid and complete tissue repair. During the first half of this stage, the granulation tissue is completely dissolved and recycled, and many of the new collagen fibers are still fragile. As maturation progresses, the fibrocytes generate new collagen until full tensile strength is returned to the tissue. Manual therapy treatments during the early maturation stage continue to focus on creating flexible, well-aligned repair tissue and improving pain-free range of motion. In the latter half of this stage, more vigorous soft tissue manipulation and exercise can be used since the collagen fibers have matured and they are now able to withstand normal tensile stress. The duration of the maturation stage can vary widely, ranging from 3 months to a full year before full pain-free function is restored to the area. Let's now consider how aging impacts the cardiovascular system. Some of the most significant physiologic declines associated with aging occur in the cardiovascular system. In the heart, the cardiac muscle fibers decrease in size and the number of collagen fibers increases, causing a thickening of the valves. Together, these changes create a progressive loss in the size and strength of the heart that leads to diminished blood supply for organs and tissues, including the brain and kidneys. In fact, blood flow to the brain is estimated to be 20% less at age 80 than at age 30. Blood vessels also thicken and become less elastic, and baroreceptors decrease in sensitivity, which contributes to a general rise in blood pressure. The rate of nutrient waste exchange is slowed due to the thickening of the connective tissue membrane around the capillaries. Total blood cholesterol increases with age, resulting in a high incidence of heart disease, atherosclerosis, and arterial sclerosis. But there is solid evidence demonstrating that regular physical and social activity, along with good nutritional habits, can delay this decline and greatly reduce the incidence of cardiovascular disease. In consideration of the manual therapy applications, it should be noted that manual therapists who work with older adults must be aware of changes in cardiovascular function. Due to the high incidence of heart disease, high blood pressure, arterial sclerosis, and atherosclerosis in this population, these clients are often on multiple medications that thin the blood,
lower blood pressure, and reduce cholesterol. Such medications increase the risk of dislodging blood clots or bruising tissue during a session. They also increase the likelihood of positional hypotension, which is low blood pressure, which can cause dizziness when sitting up or getting off of the therapy table. So we want to make very sure that our clients who are elderly, when we are concluding a session and they are about to rise from the treatment table, that they do so slowly. Always check for any signs of dizziness or lightheadedness and make sure that their feet are firmly on the ground. It's also a good idea to have them pump their feet. This is just raising the toes up off of the ground with the heels stationary, and just do that a couple of times, pumping action, and that ensures that the blood gets up to the head. So this is something that you want to be aware of. Time again for our What Do You Think segment. Why is it important to try to minimize the amount of primary edema formation in the acute phase? How does muscle splinting manifest in the case of a sprained ankle? Are arteriosclerosis and atherosclerosis seen only in the elderly population? Why or why not? Time now to consider our pathology alert. Let's take a look at heart attacks. Heart attacks, described clinically as myocardial infarctions, or MIs, occur when the coronary blood vessels that nourish the myocardial tissue are partially or completely blocked. This causes a disruption in blood flow that can lead to scarring or areas of tissue death that inhibit the function of the heart. Heart attacks can be caused by vascular disease such as atherosclerosis, which is the buildup of fatty deposits inside the arteries, or arteriosclerosis, which is hardening of the arteries, a thromboembolism, or even acute vasospasm. Well-known symptoms of a heart attack include heaviness or crushing pain in the chest, aching in the left arm, and/or neck or jaw pain. These symptoms are most common in males. In contrast, the symptoms females describe are much less obvious. They may complain of anxiety, indigestion, shortness of breath, unusual fatigue, and/or difficulty sleeping. These symptoms are often dismissed as the flu, an upset stomach, or general tiredness. A variety of factors contribute to the development of coronary artery disease, which leads to heart attacks. These include genetics, high cholesterol, hypertension, diabetes, inactivity, obesity, and stress. Successful treatment includes a combination of dietary changes, exercise, and stress reduction techniques. While many people make changes in diet and exercise, research shows that without reducing stress, the risk of coronary artery disease and heart attack is often not significantly diminished. Manual therapists need to carefully review their clients' past medical history because heart attack survivors are frequently prescribed medications that thin the blood and decrease blood pressure, which requires therapeutic precautions. The next pathology alert that we will consider is hypertension. A systolic pressure of 140 milligrams of mercury or greater, or a diastolic reading of more than 90 milligrams, indicates high blood pressure or hypertension. With no obvious symptoms, hypertension can only be diagnosed by taking blood pressure readings over time. For this reason, hypertension sometimes is called the silent killer. It may be a sign or cause of vascular or heart disease, for example, in a patient with arterial sclerosis, which is hardening of the arteries. The stiffness of the arterial wall increases resistance, elevating blood pressure. In contrast, chronic stress and anxiety lead to elevated blood pressure because of ongoing stimulation of the sympathetic response and long-term exposure to the stress hormones cortisol and adrenaline. This increases cholesterol and glucose levels and makes platelets stickier, which increases the risk of vascular damage and thrombus formation. In these cases, hypertension is not only a sign of also a cause of vascular and heart disease. When hypertension is a sign of cardiovascular disease, manual therapies may be contraindicated depending on the technique. In stress-related hypertension, manual therapies are valuable complementary therapies and are generally indicated. However, manual therapists should always weigh the risk and benefits when making treatment choices. They might ask clients with hypertension to first check with their primary healthcare provider about receiving any form of manual therapy. Now let's consider vein disorders as the next part of our pathology alert. Varicose veins, thrombophlebitis, and deep vein thrombosis, DVT, are three venous conditions manual therapists are likely to see at some point in their career. While all present some contraindications or cautions to treatment, the least problematic is varicose veins. This condition is identified by the presence of several enlarged and gonad veins in the legs, which are caused by the failure of the one-way valves. In some cases, there may be associated spider veins, indicating that capillary beds are also distended. The blood in varicose veins has stagnated and thickened, creating the risk of thrombus formation. Direct manipulation of the varicosities is contraindicated because it could dislodge a thrombus, as could deep stroking in the tissue distal to the varicose vein. Thrombophlebitis occurs when venous flow is obstructed by blood clots in the superficial veins of the leg and inflammation is present. Obstruction in the deeper veins, such as the popliteal, femoral, and iliac veins, is known as deep vein thrombosis, or DVT. The signs and symptoms of thrombophlebitis include pain, heat, and redness in the calf when a client's health history does not show musculoskeletal trauma. DVT may not display any of these signs or symptoms, but can be indicated by discoloration, pitting edema, and intermittent pain that increases with activity. It may also cause the affected limb to feel cool or clammy. Manual therapy is contraindicated in any of these situations, and therapists should refer the client to a qualified medical practitioner. Okay, so we've reached the end of today's lecture, and for assignment number 10, we're going to be using the Thinking Beyond segment as our assignment. And what I'd like for you to do is, in an essay of no less than 200 words, address the following questions. how might knowing the pathways of blood flow through the body factor into your application of manual therapy? What are some indicators that a client's cardiovascular circulation may be compromised? And since blood is a connective tissue, how does it behave similar to denser connective tissue when it comes to repairing injury? And as always, this assignment is due no later than Sunday at 11:55 p.m. If you have any difficulty whatsoever with this assignment, you may email me or send me a text message. My office hours are on Thursdays from 4 to 6 p.m. And with that, do have a great week, and I will see you in the next lecture.